Now move on to the eyes. First, test the patient's visual acuity with a Snellen eye chart. If he normally wears corrective lenses, he may wear them during this part of the eye exam. With the patient standing 20 feet from the eye chart, instruct him to keep both eyes open, cover one with a card, and read aloud the smallest line of type on which he can read more than half the letters.
DEF, POT, EC.
Note this line's numerator, 20. This is the patient's distance from the chart. Also note its denominator, which is the distance at which a patient with normal vision can read the line. The larger the denominator, the poorer the patient's vision. Normal vision is 20/20. Record the patient's vision for each eye and note whether he was wearing corrective lenses. Now inspect the patient's eyes and external eye structures. The eyes should appear symmetrical and the eyebrows should be free of scaling. The upper eyelids should partially cover the iris and the eyelashes should turn outward. Now test the oculomotor nerve by asking the patient to close his eyes. The eyelids should move symmetrically without tremors. Gently palpate the eyelids for nodules or tenderness. Then ask the patient to open his eyes and look up as you evert the lower lid to inspect the lower conjunctiva. Then have the patient look down as you pull up on his eyelid to inspect the upper conjunctiva and sclera. The conjunctiva should be pink and free of exudate. The sclera should be white. Palpate the lacrimal apparatus by gently pressing below the orbit. Pressure here should not produce exudate or excessive tearing. Next, you'll check the patient's extraocular movements to assess the extraocular muscles and innervation of the oculomotor, trochlear, and abducens nerves. Place your finger 12 inches from the patient's eyes. Instruct him to watch your finger as it moves to the upper right, far right, lower right, lower left, far left, and upper left. The eyes should move together equally and smoothly through these 6 cardinal positions of gaze. In the lateral position of gaze, they should show 1 or 2 beats of nystagmus, a fine oscillating movement that's abnormal in other positions. To test accommodation, hold your finger 4 inches from the patient's nose. Then ask him to look at your finger, at the wall behind you, and back at your finger. His pupils should constrict when they focus on your finger. Next, perform the cover-uncover test. While the patient stares at the wall behind you, have him cover one eye with a card. Then observe his uncovered eye. It should not wander or move. When he removes the card, watch the eye he's just uncovered. It should not wander or move. Inspect the patient's cornea and lens for opacities. Then test his corneal light reflex. To do this, instruct him to stare straight ahead while you shine a light on the bridge of his nose from 12 inches away. If both corneas reflect the light in the same spot, the eyes are properly aligned. Next, inspect the pupils. Normally, they're 3 to 5 millimeters wide and equally round. Also, check the patient's pupillary light reflex, which assesses the optic and oculomotor nerves. To do this, darken the room and shine your light on one pupil from the side. Normally, this causes both pupils to constrict or become smaller. For example, when the light shines on the right pupil, that pupil should constrict directly while the left pupil constricts simultaneously and consensually. Document this finding as PERLA, which means pupils equal, round, reactive to light and accommodation. Now you assess the internal eye structures. First, prepare the ophthalmoscope by selecting the lens size, turning on the ophthalmoscope, and adjusting the aperture to find the largest beam of light. To examine the patient's left eye, use your left eye and hold the ophthalmoscope in your left hand with your index finger on the lens selector. Instruct the patient to look at a fixed point straight ahead and to keep his eyes still. Approach him from about 15 inches away and at an oblique angle. Then focus a small circle of light on his pupil. You should see the red reflex, a reddish glow that fills the pupil. Keep looking at the red reflex as you move toward the patient. As the retinal details become sharper, follow the blood vessels until they converge at the optic disc on the nasal side of the retina. The disc should be a yellowish-orange to creamy pink oval or round structure. Use 1 disc diameter, 1 dd, as the basis for measuring any retinal background lesions, and use a clock face to indicate the lesion's locations. Also observe the physiologic cup, which should be about half the size of the disc, the retinal vessels, which should appear as a pair, a vein plus a lighter, thinner arteriole, the fundus, which should appear light red to brown red and free of lesions, and the macula, which should be about 1 disc diameter, temporal to the optic disc, and should contain no blood vessels. Remember, always inspect the macula last, because shining your light on it may cause tearing and pupillary constriction, which could make it difficult to continue the exam.